Dr. Grace, thanks for taking just a few minutes to update us on what's been going on. First of all, let's talk about testing capacity. How has that grown, and how quickly is it ramping up, and where do you want to see it?
Well, I've been involved with testing under Secretary Kunkel, who's the Secretary of the Department of Health. We have both worked on that. She is the lead right now, but New Mexico actually has the most testing per population per day, per COVID day, of anywhere in the whole world. And so under the leadership of Michelle Lujan Grisham, who is like a dog with a bone on this one, she is pushing testing, expanding testing capacity. She's working with the laboratories, with the state lab, Tricor lab, looking for other options for capacity. But we have started this, I think, with the ability to do about 600 tests a day. That has more than doubled, and there are plans to expand it even further. That's the laboratory capacity, but there's also the field testing and what we know of as the drive-through testing, which is our state model for that. We don't want people to go to healthcare facilities. I heard yesterday that there's 44 testing sites in New Mexico going up to 66. The Department of Health, Public Health Office in every county will be offering testing, I think by the end of this week or early next week. And so we've had the best testing response, literally, of anybody in the world. And there's a lot of incredible cooperation between the public and private sector here to make this work. I'll probably talk about that the whole time, but in almost every area, we're seeing government, state lab, private labs coming together to solve this problem and get as much testing out there as we possibly can.
Is part of the reason, I know that you've relaxed the requirements to get a test, and we'll have a link to those on our website, but is part of the reason that we're all in our homes and limiting movements because we weren't able to roll out those tests earlier?
No, that really has nothing to do with it. Testing, number one, gives folks fairly quick feedback about whether or not they have COVID. But if you're sick enough or have an exposure like travel or you're high risk and you fall in the category where you're getting a test, you should be self-isolating for 14 days, whether you have the test or not. And I don't think we were slow at all rolling it out. It was quite rapid. There were some long lines that one weekend because demand exceeded capacity, but we have a 1% to 2% positive rate. And I think all in all, we're doing extremely well. We're staying at home because we know, based on evidence, it's the only profound way to control the spread of this virus.
You talked yesterday during the governor's briefing about the doubling rate. And I think it's difficult. Most of us just don't think exponentially. We think in a line. Can you talk a little bit about why that's so important to let people know that we have to slow down the spread?
The primary reason for slowing down the spread is to, and this has become almost trite now, but to flatten the curve. That high bell-shaped curve completely overwhelms the delivery system. If we can flatten that curve, we have the capacity to take care of those less people actually over a longer period of time. So that's incredibly important. The doubling time, actually, more good news. It's been 4 days since we were at 190, and if we have, I think, something like 60 or less cases reported today, our doubling time will now be 5 days. And that's amazing. You've done the math, so just a doubling time in 30 days, if it's 5, it doubles 6 times. If the doubling time, like in New York, is 2, it doubles 15 times. Millions of, that multiplies out to a very high difference, and you've already done the math correctly. So it's the people staying at home reduces the spread of the disease. The doubling time is based on the incubation period of the virus, 5.1 days, we think, and the average number of people infected. Staying home reduces the average number of people that get infected or that can infect others, and it also therefore lengthens the doubling time.
You said that 90% of the state's ICU or critical care beds are in Albuquerque. I would imagine that's a huge challenge for you. How are you working to connect some of these rural providers, whether it's just in rural parts of the state proper or on the Navajo Nation, that sort of thing, to connect them to these resources in Albuquerque?
Well, I mentioned yesterday, we have the medical advisory team that's now up and running, headed by Michael Richards from the university, who is his whole career is actually, other than being the COO of the University Health Sciences Center, has been in disaster management. He's the head of the team. He's brought in Clay Holderman, who's the COO of Presbyterian. He's brought in Troy Greer, who's hospital leader, the CEO of Loveless Hospital. And they're literally holed up for 2 weeks, 6 feet apart, up in a facility we're using right now that is empty because those folks are working from home, planning out the strategy. There are also regional hospitals, including hospitals of Farmington, Santa Fe, Las Cruces, and Roswell, sort of a hub and spoke model where the smaller hospitals will feed to those regional hospitals. The regional hospitals will feed to Albuquerque. Transportation is a huge part of that. We've done a needs assessment. Capacity assessments are going on this week. Individual calls from these really expert hospital leaders out to the hub and spoke hospitals. The spoke hospitals will be contacting their hospitals. We're really trying to bring the delivery system together into a single delivery system for the purpose of this upcoming pandemic surge.
You're expecting, based on the modeling that you've looked at, to see the peak in infection rate when?
Well, there are a lot of models out there, and there are a lot of ways of looking at it. I think that I would predict that we'll see a surge here this week in some areas of the state. I think our data suggests that we may see a surge more in the middle of the month or toward the end of the month. Remember, as people stay home and as that doubling time increases, that will move the peak out further and further, which allows even more time to get ready, more time to get additional equipment, ventilators, personal protective equipment, which I'll call PPE from now on. And so this doubling time really could be a great opportunity for the state to get additional resources to deal with the surge and to slow the angle of that curve so we don't immediately overwhelm the healthcare system, as we see on TV has happened in other states.
Sure. As you speak to the hospitals around the state and they talk to you about things like adding beds in tents or temporary locations, is there sort of a best practice as to what you want those beds to be used for? Do you want them to be used for standard medical issues and leave the COVID to the emergency rooms? How does that work?
Well, there's some principles that guide the decision making around that Mike Richards has taught me. And the first principle is, number one, we want people as much as possible to be cared for in their own communities within the limits of the resources there. So in other words, if someone just needs general hospital care and can be cared for in a rural hospital, there's absolutely no reason to transfer them to a spoke hospital or the hub in Albuquerque. Number two, that's really important as well, is that in these situations, we do not want to take care of people who are on ventilators in tents. And then the third thing is, I think we can lift up the capabilities of those rural hospitals more than they might think by a number of mechanisms. One is teaching about COVID through Project Echo, and we're sponsoring and working with them every Friday for physicians at noon. And then they have multiple conferences going on. And number two is, I think, one of the big dilemmas in this is a lot of our older physicians, and I guess I'm in that group, really shouldn't be going into hospitals if they're over 60. They're at much, much higher risk. But there's absolutely no reason that a retired pulmonologist can't sit in their living room and walk a primary care physician in a rural hospital through basic care or talk about the need for transfer. And so we're really going to go to an all hands on deck model, trying to involve every care provider in the state in some way or another. And our phones basically ring off the hook from retired physicians who want to figure out a way to help, and particularly if they don't have to go in at age 75 into an intensive care unit with covered with PPE. So we think we've got a great resource there, and the volunteer spirit in the medical community has been wonderful. The Medical Society has reached out multiple times. How can we help? How can we help you organize? And so we're taking advantage of all that.
Dr. Scrase, we appreciate your time and your work, and we know you have a lot more to do. We look forward to hearing from you again soon.
Yeah, thank you very much. Appreciate your interest. And can I say one more thing?
Absolutely.
For all those folks out there, please, please stay at home. Even if the grocery stores have special hours for seniors and you're a senior, it's better to have a teenager in your neighborhood take orders, or you call in those orders and have someone pick those groceries up and leave them on your porch like the governor mentioned yesterday. There's nothing that will help the medical personnel in the state more than simply all of us staying at home, as I am today. Thank you.
Thank you.